Welcome to Strike Stroke. My name is Dr. Mekdes and I'm a neurology resident. My passion is to learn neurology and teach you what I know, more specifically in regards to stroke. So today we will talk about stuttering stroke, or also known as Capsular Warning Syndrome. So the term Capsular Warning Syndrome was first introduced to us on an article that was published by Donna et al. In May 1993 in the American Academy of Neurology. In this article, the authors talked about why they termed it Capsular Warning Syndrome. They also talked about what they think caused this syndrome, and they discussed the presentation, or how patients present who are experiencing the Capsular Warning Syndrome. So we will talk about the article, and then we'll talk about today how things have changed since the article was published in regards to stuttering transient ischemic attacks. So in the article, they mentioned that the reason why they called it a Capsular Warning Syndrome at that time was because they noticed, after observing 50 patients, that the pattern seemed to be restricted to the internal capsule, which is a specific area within the brain that allows sensory and motor fibers that usually feed the face, the arm, and the leg, which is how the patient would present, either having pure motor weakness affecting the one side, the left face, arm, or leg, or they can have mixed sensory and weakness where they would feel numbness affecting the left face, arm, or leg. And the typical presentation for them would be where they would be stuttering, which is a term that is used today to describe the Capsular Warning Syndrome, is that they would have these symptoms come on right away because it is a vascular abnormality where all of a sudden the vascular system that's feeding a specific part of the brain is shut off, and the person would experience deficit in that area because that area is not getting the nutrition, oxygen it needs, and they will have weakness on that side, but somehow it will recover back to normal, and then they will have it again, and then it will recover back to normal, usually the symptom lasting 20 to 40 seconds. And the patients who are having a Capsular Warning Syndrome would not have any cortical sign. In this article, the proposed pathophysiology, or the reason why this happened, was that they said just based on location, it's likely a small vessel disease, because these are small vessels that are coming off of large vessels and penetrating the internal capsule. So they propose it's likely one single vessel that is feeding the internal capsule that's diseased, meaning it either has thickened up or has microarthroma, plaque formation in that artery, which decreases the size of the artery. Also, they believe there might be some hemodynamic changes that occur in a patient who have this diseased single artery, meaning that their blood pressure might have changed that causes symptom to surface because this artery was already narrow or diseased and little blood was going through it. But when the blood pressure changes, not much blood can go through it because that area that was feeding was already under a lot of stress. So the patient at that point will have symptoms. In their presentation, they did not see any artery to artery, meaning any artery that has thrombus formation that could have sent a small clot to that area. They didn't also see any heart involvement where a clot formed in the heart and went and got large in that area, causing the Capsular Warning Syndrome. In regards to treatment, in this article they mentioned that most of the patients were resistant to treatment, meaning if they were to receive IV thrombolytics such as IV TPA or antiplatelet medications such as aspirin or Plavix or another antiplatelet agent, they were resistant to treatment, most of their patients. So what do we see today in regards to the Capsular Warning Syndrome since it was first published in 1993? So most neurologists don't like to use the Capsular Warning Syndrome terminology because it is a misnomer. The disease is not only restricted to the internal capsule, the patient could have stroke in the corona radiata, in the internal capsule, as well as in the basis pontis. So therefore, the term Capsular Syndrome does not describe other regions that are involved in these patients who are presenting with stuttering transient ischemic attacks. In regards to pathophysiology, or the reason why this happens, yes, it is agreed that it is likely due to a small vessel disease based on location, because it is a subcortical stroke, and that it does involve the areas we just talked about, and those areas are fed by small arteries that branch off of large arteries, as we talked about before. And yes, it is agreed that there is a disease process within these small vessel arteries, either lipohydrosis, where they thicken up because of poorly controlled hypertension and other risk factors. Also, they can be thrombus formation within these arteries, or microarthroma. Yes, there could be hemodynamic changes that affects the person because the arteries are already diseased. Yes, all those theories that were mentioned in the initial article are agreed upon, but in addition, others propose there might be vasospasm, where the artery would just shut down on itself and open up, shut down on itself and open up, which can lead to a transient ischemic attack the person experiences. Also, there is theory that yes, we can have artery phenomena where thrombus formation on a large artery could have moved enlarged into a small artery, causing stroke, and maybe that thrombus is so small it moved off and the patient had resolution and their symptoms. Also, there's proposed that the heart could also be involved, where they might throw a small clot and that will get lodged in that area, leading to transient ischemic attack. In regards to treatment, it remains the same. We have noticed that some patients are resistant to treatment and some are not, and the treatment has not changed. It's IVTP if they're within the window, or if they're not, then they get antiplatelet therapy. So it is important, if you or someone near you is experiencing the stuttering transient ischemic attack, to come to the emergency room right away, because the chance of having a stroke within the next 7 to 14 days is up to 60%. By coming to the hospital right away, you would decrease the chance of having a stroke by getting the appropriate treatment, and also you will be able to identify your risk factors for stroke so that you know how to prevent these symptoms from happening again. Therefore, you will continue to have your independency and be able to be productive within the society and be able to be there for your family. So, in summary, the capsular warning syndrome is a misnomer. Some neurologists prefer to use stuttering transient ischemic attack to just describe the clinical presentation. People who are having this stuttering transient ischemic attack will have weakness affecting one side of the body, usually involving the face, arm, and leg, and it is subcortical. They will not have any cortical signs, and these symptoms will be transient. At least 3 to 4 times within a 24-hour window will be classic for this syndrome. Location is usually in the corner radiata, internal capsule, and basis pontis, which is different from the initial description of pure internal capsule location. These areas are areas that are affected by small vessel disease leading to lacunar stroke, and the treatment remains the same. And patients who present within 4.5-hour window will receive IVTP, followed by antiplatelet management after a 24-hour window. Also, strong risk factor modification. Thank you for watching. I hope you found this information useful. If you want to learn about small vessel disease, make sure you go back and watch my other channels discussing lacunar stroke. In the next episode, we'll talk about a cortical sign, specifically gaze deviation. And always remember to dial 911 if you or someone near you suddenly can't see, can't speak, can't walk, or can't feel. Let the operator know that you or someone near you might be having a stroke, so that you or the individual near you can be transported to the nearby comprehensive or primary stroke center for rapid stroke analysis and tailored treatment.